All right. Oh, great. Dr. Reed, I see you here. Hello, and I'll let you take over whenever you're ready.
Excellent. Thank you very much. Hello, everybody. I'm Robin Reed. I am one of the pathologists at Seattle Children's Hospital, and I am the renal pathologist here. I share my service with two other pathologists, but I see the majority of cases. And I'm going to be sharing with you today some interesting kidney biopsies, along with a number of my colleagues in the pediatric nephrology division. And let me get that. So that's okay. I believe that that is now projecting the way that it should, and I'm seeing people nod. So, okay, excellent. Fabulous. We have nothing to disclose. We have no conflicts. And we are going to start with a case presented by Dr. Amber Kazi in conjunction with Dr. Gordillo.
Hi, good morning, everyone. I'm Amber. I'm one of the first-year fellows. Hopefully you can hear me okay.
Yes.
So I am presenting IA. So she's 12 years old. She has an interesting history of neonatal HSV, but otherwise had been healthy. She came into us with elevated blood pressures, extremity edema, proteinuria, and then gross dark hematuria. So on her history, so she actually presented to the ED quite a few times. So when she first came to our ED, it was on the 9th. She had a couple days of neck pain, thought to be lymphadenitis with normal labs otherwise. Her urine at that time already started showing 2+ protein and 3+ occult blood. So we were contacted, compliments were sent, and she was doing well. She was sent home on clindamycin just to treat the lymphadenitis. However, click next, she presented again to the ED on the 11th because of her neck pain, and now she was having facial swelling. Her UA again showed proteinuria and hematuria, but at that point was diagnosed with acute otitis media and a cystitis, so sent home on ceftonir as well. And once again, she presented on the 14th with rash now and edema to her legs bilaterally. And at that point, we thought most likely a GN, complements an ANA and a dsDNA were drawn. And at that point, because of her presentation and looking stable, we had sent her home for outpatient follow-up. But on the day of admission, a few days later, her edema had basically spread from her extremities to her abdomen, hands, and face. Her blood pressures had become more elevated at 135/91. Her exam was notable for pitting edema or non-pitting edema of her ankles and shins and her wrists as well. And on the next slide, the labs that we had drawn. So labs on the day of and a couple from before. All of her electrolytes and her creatinine actually looked okay. Overall, the rest of her panel looked fine. Her CBC didn't show any pancytopenias or anemia. Her UA at that time did show 2+ protein, 3+ occult blood, and had a micro showing many RBCs and some white blood cells as well. We did a UPC that had a number of 2.22 on that urine. And I will say, I think we looked at her urine under microscopy, but it has been a while, so I don't remember exactly the findings on the microscopy. Her complement testing, so the testing from that previous had come back from the ED, and the testing from that day had shown low C3, both on the 9th and the 14th, and then actually low C4 on the 14th as well. Her ANA titer was slightly positive, and then later in that course, we had found out that her dsDNA and her other antibodies were negative as well. So because of her kind of positive ANA and her hypocomplementemia, we decided to go ahead with biopsy.
Yeah, so when we received this biopsy, we got a couple of cores of tissue, and I'm going to start each of these by showing you the low magnification trichrome image to give you kind of an overview of how this kidney looked. In this case, you can see that the cortex, the tubulointerstitium is really well preserved in this kidney. There's not a lot of interstitial inflammation, edema, or fibrosis. And the glomeruli at this magnification at least look okay, although you kind of get the feeling there's something going on with this one here. When we looked more closely, the glomeruli were uniformly enlarged and hypercellular. They looked very busy. And most of the busyness in these glomeruli seems to come from these kind of swollen, activated looking endothelial cells. But you can see on this PAS stain that there's also a number of circulating inflammatory cells in this glom. PAS is kind of nice because it will highlight myeloid cells that's kind of bright magenta, and you can see a few of them kind of passing through in this image. Our Jones stain was a little weird during the time when we took this, but I hope that what you can see in this image is that there's maybe a little bit of endocapillary proliferation going on here, and that, again, there's a number of circulating inflammatory cells. So these are neutrophils. You can see the polymorphonuclear segmented nuclei here. So we're kind of coming around to the idea here that this looks like it's an exudative glomerulonephritis. Again, here you can see a number of these circulating inflammatory cells. And again, just an enlarged, busy-looking LOM. And here, again, this glomerulus had many circulating inflammatory cells within it, way more than you'd expect under normal circumstances. About 5% of the glomeruli that we had to look at had crescents. So this glomerulus has a small cellular crescent. The majority of crescents that we saw were cellular, but there were occasional ones that were fibrocellular and even a rare fibrous crescent. So here's an example of a glomerulus with a kind of getting toward a fibrocellular crescent and even a little bit of destruction of Bowman's capsule. And then here's a rare glomerulus that has a fibrous crescent. There was a little bit of patchy interstitial inflammation, not a ton. You can see some in this image here, and it was composed of lymphocytes and plasma cells. So based on this, the light microscopic impression was of an acute exudative glomerulonephritis with rare crescents. We did immunofluorescence microscopy. IgG and IgA were entirely negative. This is IgM had some focal and segmental staining. You can see that some of it is probably like podocyte protein resorption droplets, and then some of it seems to be just this little bit of segmental staining. I feel like IgM does this sometimes, particularly in areas of the glomerulus with injury, and it's hard to say for sure what it signifies. However, the C3 staining was quite different. It was very bright. It was 2 to 3 plus, and some glomeruli had this pattern of staining where you've got kind of this chunky, granular, nearly confluent staining in the capillary loops and probably some mesangial staining as well. Other glomeruli looked like this with the C3 stain, where it wasn't quite as sort of heavily stained, but you can see this kind of chunky granular staining in capillary loops that again kind of gets confluent in some areas. And this is a close-up of yet another glomerulus with that pattern of staining, where you can see that this is pretty much hitting capillary loops, hitting capillary walls. The C1q was negative, C4 was negative. So this was pretty much a C3 only staining pattern. So based on this, the afternoon that we received the biopsy, I called the team and I said, this is an exudative glomerulonephritis. It's got pretty much exclusively C3 staining. The things to consider here are, I was favoring a C3 nephropathy given the staining pattern, but a post-infectious glomerulonephritis could look like this too, although it seemed odd to me that there was no IgG staining at all. And so they and we sort of proceeded on that differential diagnosis until a couple of days later when my electron microscopy came back. And the EM was striking because the major finding was these large electron-dense subepithelial humps that you can see in this image here. And then the other finding in the EM was pretty extensive foot process effacement. So you can see some preserved foot processes up here, but a lot of these capillary loops show fusion and effacement of foot processes. Here's a close-up of some of these subepi humps. You can see that they're large, they're round, they're located on the subepithelial surface. And it's really a pretty typical appearance for a post-infectious GN, although occasionally C3 nephropathy can have the same ultrastructural appearance. Here's a few more. You can see that these are kind of hanging out at the mesangial waist, but there's also some out in the periphery. Here's maybe one here. This maybe is one here. Occasionally, they seem to kind of extend into the glomerular basement membrane or be intramembranous. And rarely you could see some small subendothelial electron-dense deposits, but this was really the exception, and the humps were the rule in this case. And here's just one more picture of the humps before we, and some intramembranous deposits here as well. So based on that, I ultimately signed this out as descriptively as exudative glomerulonephritis with C3 staining and subepithelial humps, C comment. And then I also commented on the presence of cellular and fibrocellular crescents in this case. And when you're considering a diagnosis here, your differential is really post-infectious GN versus C3 glomerulopathy or C3 glomerulonephritis. And the things that favor post-infectious in this case are the exudative pattern, the fact that there's this kind of garland pattern of C3 staining by immunofluorescence, and the presence of subepithelial humps. But the things that might make you at least consider the possibility of C3 nephropathy are the total absence of IgG staining, and the fact that there's proteinuria. Like, it's not raging, but it is subnephrotic proteinuria, which is a little funny for post-infectious, although not completely unheard of. But on the other hand, you can have absence of IgG staining in post-infectious. It's thought to be kind of perhaps a later stage in post-infectious glomerulonephritis. And overall, at this point in time, it's just really hard to tell what entity you're dealing with. And so what I said in my comment and what we did is continue to follow up, because that will be probably the most helpful thing in distinguishing between these two entities. And in general, the question of how to distinguish between post-infectious GN with dominant C3 staining versus C3 glomerulonephritis is challenging. There's a lot of overlap. You can have infection preceding C3 glomerulonephritis, and a lot of these patients have a positive ASO. Both can present with hematuria and proteinuria. Both can have endocapillary proliferative or exudative patterns. Those two patterns are present in about 20% of C3 glomerulonephritis cases. And you can have sub-epi hump-shaped deposits in up to 40% of C3 glomerulonephritis. So, like, what do you do? So when the C3 glomerulitis working group put together their recommendations initially in 2013, what they suggested is to call cases like this glomerulonephritis with dominant C3, and if you've got an association with infection, to put that in your top line, but not to commit to one diagnosis or the other. And then to continue to follow these patients with their clinically and with laboratory values over the next 8 to 12 weeks. And essentially, if it clears up on its own, you look back and you say, okay, that was post-infectious. And if it doesn't resolve on its own, then you should consider conducting further investigations to determine whether this could be a C3 nephropathy. And there's a study from 2016 that I thought was really nice, looking at pediatric patients with C3 dominant, what was called C3 dominant post-infectious GN. And in that series, virtually all of their patients, it was a small series, it was like 13 patients, but all but one regained their baseline renal function without any clinical intervention. So it's reassuring to know that the great majority of these patients probably will do well. Now I'll hand it back to Amber to disclose how this patient did.
Thanks, Robin. So she did well. During her admission, she responded fine to dialysis. She did require some help with her blood pressures on discharge. And it looked like when she saw Dr. Gordillo in November, her edema was already better. And then when she saw him again in December, her complements had normalized, and she was dizzy, so she was taking off her blood pressure medication. So far doing much better.
That's great. I wonder if any of my colleagues on the call here have had experiences with clinical scenarios like this one, where you got a dilemma as to whether this is post-infectious or C3.
So, Robin, this is Charlie. I think it doesn't have to be a dilemma. I think there's an emerging consensus that they are just part of a spectrum, and what we would call either post-infectious GN or increasingly infection-related GN is really a subset of C3 glomerulonephritis. And you can think of it a couple of ways. The classic post-infectious or infection-related GN is a C3 glomerulonephritis that resolves on its own quickly, and the other is one that isn't. There's also some pathophysiologic studies to suggest that maybe people who are susceptible to a C3 glomerulonephritis have an episode of infection that is a precipitating second hit that allows the disease to initiate and evolve at a specific time. But I don't think it makes sense to go through a lot of contortions to try and figure out something that can't be figured out except in retrospect.
I appreciate that comment. Thank you. It is interesting to me that that post-infectious, I think I remember learning in medical school, is characterized by codominant IgG and C3 staining. And so it took a little bit of kind of reading and learning for me to realize that a substantial number of these don't have a lot of IgG staining in them.
Right.
Yeah.
Charlie, this is Leah. I guess I'm just playing devil's advocate here, and I'm not an expert on C3 nephropathy, but I thought that we use eculizumab at times when things are bad, and we would never do that if we just thought someone was going to get better from a post-streptococcal GN. So isn't that an important reason to distinguish them?
That's if you could distinguish them, Leah. So part of
Sure.
it is, speaking strictly as a pathologist, and not as someone who administers eculizumab, my experience in looking at biopsies and talking to clinicians is I'm sometimes impressed at the liberal use of eculizumab. I think you wait to see, you use eculizumab if they don't resolve, perhaps. It's not an immediate therapeutic as opposed to seeing the course, and you can still have the same entity with, for a variety of reasons, have either a resolving course or not. And I don't think that makes them, it makes them distinct disease manifestations, if you will, but I think it's part of a spectrum. And I think you do need to consider that as to whether or how soon you would use eculizumab in one of those patients. I don't know if that answers your question really, but I don't think all of these cases mandate use of eculizumab, and I do think they are part of a spectrum.
Thanks. All right, should we move on to the next one? Our next case will be presented by Dr. Shaina Menon.
Thanks, Robin. Okay, next slide. So this is a case of a previously healthy 6-week-old infant who resident of a remote village in Alaska, who was transferred to Seattle from an outside hospital in acute heart failure secondary to supraventricular tachycardia in the setting of paraflu infection. Prior to that admission, 3 days prior, she was seen by a community health aide in her native village, where she was seen for poor PO intake. She was having cough for 3 days. She was noted to be in SVT at that time by the health aide. They did vagal maneuver and she had normal sinus rhythm. She was transferred to a regional hospital where she had recurrent SVT. She had was given adenosine, did not have any improvement, underwent cardioversion, and then was transferred to a bigger regional hospital in Providence, in Anchorage. At the Anchorage hospital, she was noted to be in extremis. She had a pH of 6.5, lactate more than 20. She was loaded with amiodarone for SVT, but this had a normal rhythm, but then had tachyarrhythmia again, got more amiodarone. She had a catheter, Foley catheter placed during this ED visit, ED stay, and was noted to have minimal urine, which was red tinged. Had a creatinine that was 0.5 at admission, which increased to 1.2 during that hospital stay. She had hyperkalemia, which was managed with K-exolate. This UA was sent to the lab, which had 500 milligram per deciliter protein, 100 milligram per deciliter glucose, more than 20 red cells. And because she was doing so poorly, she was transferred to Seattle Children's Hospital. So when she came to the hospital, by then she had been successfully cardioverted. She was on a normal sinus rhythm. She was started on a Lasix drip because she was had low urine output, but with that infusion, her urine output improved significantly. Over the next couple of days, she gradually improved. She was weaned off epi. She was taken off esmolol infusion. Her LV function was improving. Creatinine peaked at 2.8 and then gradually started coming down. All of her other electrolytes were normal. A second UA was sent in Seattle, which was very dilute with 1+ protein, 3+ blood, had few red cells in it. Had a serum albumin that was 3.3 at admission, but after about 3 or 4 days, a repeat value was 3.8. this is what her creatinine looked like when she came in. So it peaked at 2.8, and then gradually she kind of came down to around 1.1 over the next week or so. During this admission, she was noted to have hyponatremia, hyperkalemia, which nephrology was consulted for. We saw her for AKI, and then as things started getting better, we saw her again for this hyponatremia, hyperkalemia, which was presumed maybe she had tubular dysfunction in the setting of her recovering AKI. She was getting hypotonic feeds, so started on some sodium supplementation. Things stabilized, and she was sent discharged back to Anchorage after a 24-day hospital stay. She was sent home on atenolol for her cardiac by cardiology, and she went home on sodium bicarb and had a creatinine of 1 at the time of discharge. They stayed in Anchorage to have a cardiology visit before they went back to their village. So labs done 10 days post-discharge, her creatinine had gone up to 1.5 and potassium was 6.8. There was no intercurrent illness. She had normal rhythm, normal function on echocardiogram. She was admitted locally because of the high potassium, got some peteromer there, got IV fluids. But this creatinine on subsequent checks just continued to increase, and it was 2.2 during the course of a week. So she was brought back to Seattle for admission, this time to nephrology to figure out why her creatinine was 2.2. When she was admitted to nephrology, her UA was dilute again, had no protein on this dilute on dipstick. At trace blood, 1+ leukoesterase, a UPC was 3.2 and a serum albumin was 3.9. Since we didn't have any, good reason why her creatinine was doing this, so this is where she had improved at the end of December, and then now we had this rise in creatinine again, without any good reason why the creatinine was elevated. So we went ahead and did a biopsy in this patient.
Yeah, so I'll tell you in advance that this is not a case that we have a definite answer on. So please play along at home and help us out with this one. This is what the biopsy looked like at low magnification on trichrome. Really different from the last one. You can see that there's diffuse interstitial fibrosis, and the tubules don't look super healthy here. It was like this kind of throughout the entire core. Looking more closely, remember this is a 2-month-old baby. And so the fact that the glomeruli are small and immature looking is maybe not super shocking, but I want to make the case for you that even compared to your average 2-month-old baby, these were unusually small and immature looking and simplified looking glomeruli. And again, they're in this background of fibrosis, which almost has this kind of fibroplasia look to it. And let me just, stepping back, the tubules were frequently atrophic. There were areas of well-preserved tubules. However, we did not see any dilated tubules to speak of. So here are some kind of typical small immature looking glomeruli. But in addition to these, we also have some very small glomeruli. And we have a number of them, enough that I don't think this is just tangential sectioning. I do think that we do have just abnormally tiny glomeruli in this kidney with this very sort of immature look where you can see this sort of crown of prominent epithelial cells sort of surrounding the edges of them. So for comparison, I went back to our autopsy files and pulled out 3 age-matched controls of term 2-month-old infants to show you what 2-month-old baby glomeruli are supposed to look like. And so these are from 3 different patients. And you can see that, yeah, these glomeruli are small. They do have a more simple looking sort of capillary tuft than mature grown-up glomeruli. And they do have these prominent epithelial cells. And some of our patients' glomeruli did look pretty much in this spectrum. But once again, going back and looking at this patient's kidney, you can say maybe this is an appropriate 2-month-old baby glom, and maybe this is, but all of these guys here, they're kind of unusual. And this glomerulus here, and this little tiny glomerulus here, also like kind of out of the spectrum of normal for age. And even compared to newborn, like term newborn kidneys, this would be an unusual appearance for these glomeruli. We were struck by how kind of simplified the capillary tuft looked in many of these glomeruli, more pronounced in some areas than others, which maybe makes sense if you think that superficial glomeruli are less mature than deep glomeruli. But among the deep glomeruli, we saw a different feature, which is that at least some of them had these areas of mesangial increased matrix and cellularity. And so you can see a cluster of 3 glomeruli here with too much mesangial stuff going on. Perhaps even you could call it mesangial sclerosis. And here's a little tiny glomerulus with some mesangial sclerosis at the edge. And then here's a few more, and this is how they appeared on the Jones stain. We saw segmental sclerosis in just a few, maybe about 3% of the glomeruli, and that's an example. And we also saw a few crescents. About 4% of the gloms were involved by crescents, mostly cellular. There were rare fibrocellular crescents as well, and these are examples of that. Immunofluorescence on this case was entirely negative. And then electron microscopy showed microvillus transformation and some quite extensive near universal foot process effacement. So you can see the basement membranes themselves look fairly normal, and there were no immune complex deposits, but you can see complete foot process fusion along here. You can see near total effacement here with maybe a few preserved foot processes here. Here we do have a focus of preserved foot processes, but again, the majority of it showed widespread effacement. And this is to illustrate more of that. So it's a perplexing case. And to summarize the findings again, a subset of the glomeruli in this biopsy seem to be small and simplified. There is a subset of glomeruli with mesangial hypercellularity and sclerosis. There were rare cellular and fibrocellular crescents. There was rare segmental sclerosis. By EM, there was widespread foot process effacement. And then that background of diffuse interstitial fibrosis and tubular atrophy without significant tubular dilatation. So I thought a lot about this case, and I'm not sure what this is. I think it has many features that match with diffuse mesangial sclerosis. So the diffuse mesangial sclerosis is characterized by immature glomeruli, by mesangial sclerosis, which this has in at least some of the glomeruli, and DMS also has interstitial fibrosis. The things that make me kind of shy away from committing to that diagnosis are that the mesangial sclerosis is really only present in a small percentage of the glomeruli here. And also there are crescents, which seems odd, although I did find at least passing reference to that occasionally being a feature in DMS. There's morphologic overlap between DMS and congenital steroid-resistant nephrotic syndrome, so like NPHS deficiency. However, typically, steroid-resistant congenital nephrotic syndrome, the mesangia have less sclerosis and more hypercellularity. And also in this entity, typically you do see dilated tubules, although maybe that's not a feature you see at the age of 2 months. Finally, you could shoehorn this into just a general entity of FSGS. There is foot process effacement and segmental sclerosis, but it feels like that's not a very specific diagnosis for this very kind of specific looking entity. The immature glomeruli aren't typical. There's crescents present here. And then there's this diffuse interstitial fibrosis. So just to remind you what textbook diffuse mesangial sclerosis looks like, these are pictures from the AJKD Atlas of Renal Pathology from an article contributed to in part by our by the excellent Dr. Alpers. And you can see that these glomeruli really have sclerotic looking mesangium. They look more sclerotic than the glomeruli in our case. It does have the interstitial fibrosis that our case has. And then this is a picture also from the Atlas of congenital nephrotic syndrome finish type. And you can see that at least in this glomerulus, the mesangium is expanded, but it's more kind of hypercellular rather than sclerotic. And then while I was pondering this case, we actually had a consult case come across our service of a patient with Dennis-Drash syndrome, so WT1 mutation, and this typically causes diffuse mesangial sclerosis. And so I'm just going to share a couple pictures from that. She had actually had a nephrectomy for a Wilms tumor and had undergone neoadjuvant chemotherapy previously. And what we saw in her kidney was very tiny glomeruli, often in areas that I think were probably perilobar nephrogenic rests. You can see that these globs are about the size of a typical tubule. And then deeper in the kidney, you could find occasional glomeruli with true mesangial sclerosis. But one thing that I was struck by in this case is that a lot of her glomeruli were actually morphologically normal. So it made me feel like maybe a diagnosis of diffuse mesangial sclerosis doesn't have to hinge upon seeing mesangial sclerosis in the majority of glomeruli. Perhaps you could have many normal appearing glomeruli even at age 3. So I cited this out descriptively, but I said in my comment, this has features that overlap with diffuse mesangial sclerosis. Really not sure what's going on here, but wow, this is a 2-month-old. This is very strange. You should do genetic testing, which of course was already underway. Back to you, Shaina.
Thanks, Robin. So we did genetic testing because diffuse mesangial sclerosis can be associated with the WT1 mutation, and that has implications for screening for Wilms tumor and everything. Interestingly, this is what her genetic testing showed, and I'll discuss this in a little bit more detail next. But we knew she had CPT1A deficiency, that's carnitine palmitoyl transferase 1A deficiency, and then she was noted to have this TTN gene mutation, and both of these were considered pathogenic variants. And then she had a variant of unknown, uncertain significance. So the CPT1A, and she had XX chromosomes in addition to that. So the CPT1A deficiency that she has, that was known based on her birth screening. It's a fairly common genetic variant seen in the Alaska Native population, and typically these patients don't have significant symptoms from it. They may present with hypoglycemia or seizures when they have prolonged fasting, but usually it's pretty mild. And that's the reason why it's part of the birth screening in Alaska Native population. And then she had this TTN gene mutation, which encodes a protein called titin, which is involved in the cardiac and skeletal muscles and dilated cardiomyopathy, but not really known to associate with SVT, which is what she presented with. So again, it's kind of unclear what implication this has for future. I think genetics recommended that she undergo just screening with cardiology regularly for this, in addition to her SVT stuff. Beyond this, as of now, she is doing well. She is now 5 months old. Her creatinine is 2.1 to 2.2. It hasn't really improved from that point. And the other puzzling thing is, even though she had that nephrotic range proteinuria, she has nephrotic range proteinuria on her UPC, but her albumin is normal. She does not have nephrotic syndrome on clinical exam. She is on a small amount of bicarb supplementation, which we're kind of slowly weaning that down. And then she had issues with hyperkalemia, so she is getting some patiromer mixed with her formula and breast milk, which is, again, we are gradually going down on that. But overall, we've discussed with the family that, we think she has diffuse mesangial sclerosis, and these kids typically end up, they do progress to worsening chronic kidney disease and requiring renal replacement therapy. So the family is aware of that, and we're just keeping a close watch on her labs right now.
This was one of, I feel like I've had a run of cases recently where we put a lot of, we looked at the clinical picture and said, wow, this looks really genetic. We're going to do an exome and we're going to get the answer. And then we didn't get the answer. I wonder whether other folks have thoughts as to whether diffuse mesangial sclerosis is the correct bucket to put this entity into, or whether there's other diagnostic considerations that we should be having on this kidney. I don't think her arrhythmia is enough to explain the degree of interstitial injury in this kidney. And I'm scrolling back just to, again, show this really, I think, kind of wild looking picture of interstitial fibrosis and funny small glomeruli. Does this ring a bell for anyone else?
Hi, Robin. Thank you. Thanks. This is Ram here.
Yeah.
Really fascinating case, and I agree with you. This is like it's kind of screaming that it should be genetic, but maybe it's different, right? It could also be something that's a dysregulation of expression of something rather than a coding mutation that would be screened for in those tests. So kind of related to that, when we think about WT1 expression in Denny Drash and even DMS, is the expression usually decreased? So if you were to stain for WT1, would that be reduced in those cases?
Yeah, so actually in our recent Dennis Drash case, I did WT1 staining just out of curiosity, and we have WT1 antibodies directed against both the N-terminal and the C-terminal of the protein, because there's some WT1 rearrangements that are involved in diagnosis of tumors. I saw WT1 expression, and I do not specifically, I couldn't find the stains when I put this case together. So I don't recall the pattern of expression, but there was WT1 expression present within the glomeruli in this case. I didn't do it in my patient's case. I don't know. I just don't have a lot of experience with doing WT1 staining in kidneys, which seems kind of funny now that I'm saying it.
So, Robin, I have another question. Do you know how broad was the genetic screening panel used in this case? Was it whole genome? Was it a targeted panel? In which case there may be other possibilities that just weren't looked for.
This was
So
whole
this was
whole exome sequencing.
It was a whole exome.
Yeah. So, an exome isn't going to catch large introns. It's not going to catch intragenic DNA. It is possible that a whole genome or a long read genetic sequencing might pick up things that your whole exome misses.
Or as Ram was referring to, it's not something that's specifically coded. It may be a regulatory element or something involved in modulation. I too am very impressed by the degree of fibroplasia and was thinking it has something to do with that strikes me as that was probably right there from the outset, or dysregulated stromal development, but I don't know the best way to go approach that.
Yeah, throwing a WT1 onto it is very simple, and we have that stain in house. So I think doing that with maybe some of my control kidneys might at least shed some light on what's happening.
Yeah,
it's
you'll learn
probably
something, but you won't get a diagnosis.
Well, it'll tell us something about expression, but yeah, it's not going to give us a diagnosis, but maybe it'll at least give us a hint. I don't know.
Yeah.
I'll be if she comes to transplant, often these kids get a nephrectomy because they have persistent proteinuria. So it's possible that we'll have more tissue to look at, although I'm not sure if more is going to be better in this case.
It could also help you if you have a sense of which pathway, it might promote speaking to the geneticist to say, is there any other testing that could be done? On the immunology side, one of our rheumatology fellows reviewed cases with IPEX. So this is mutations in FOXP3. It's a Treg deficiency. It's a well-known defect. And she looked at all of the patients with what's known as IPEX-like syndrome, which is basically IPEX, but their FOXP3 was normal, and did sort of modern sequencing. And these were patients going back many, many years. And the most common genetic mutation she found was FOXP3. All of these patients had FOXP3 mutations checked. It's just that the technology had advanced to look for all the things you're talking about, duplications, et cetera. So it could be this.
Yeah, I just had a conversation with our biochemical geneticist about another case. It was a suspected ornithine transcarbamylase urea cycle defect. And she was saying that up to 15% of those cases that are clinically diagnosed, you do not find a genetic alteration, and probably at least some of them are in promoters or are in upstream sequences far away from the actual gene that you might be able to pick up by doing long read sequencing, but you're not going to pick up in a typical targeted panel or an exome. So I feel like there's still a lot of mysteries in the genome that we need to continue investigating, and I think we're sort of rapidly getting to the era of doing whole genome sequencing as our first line test in at least some clinical settings. It kind of creates new problems because it gives you such an avalanche of data that you wind up with a lot of VUSs and a lot of difficult to interpret data. But maybe it'll start to shed light on cases like this where, you know, you did the exome, nothing came up, but it really, really looks genetic.
Yeah.
Yeah. It would be nice to be able to give this family counseling, in part because, of course, if you're capable of having one child, you're capable of having another one. And it'd be nice to know whether this is likely to recur.
Yeah.
Yeah. All right. Well, Sean, you're already unmuted. You want to go ahead and present the final case?
All right. Well, so this, next slide. So this is going to be a lot simpler because it's kind of a straightforward classic presentation. I was referred a patient. This was a 6-year-old female who was referred with the clinical diagnosis of HSP and an abnormal urinalysis. So the story was, this is the history that I got from the family, and it was a little bit of a challenging history because it was with a Romanian interpreter. But the story was that the child had about a 3-week history of some sort of rash. She initially went to the emergency room, got a cream for it, nothing seemed to help, so she went back home and then came back to her primary care physician, where she had the description of what sounded like a purpuric rash on her legs. She had swelling of her calf and knee with associated joint pain. The mom referred to the pain in the knee, but she also said her calf was swollen. She did not, however, have any abdominal pain, vomiting, or diarrhea. No obvious hematuria or dark urine, previously healthy, no medication use, no NSAIDs use, no family history. And the PCP made a clinical diagnosis of HSP, ordered labs, and they were notable on the right there, which essentially showed a little bit of anemia, but not a significantly abnormal CBC. Her BUN was within the normal range, I believe, on our chart, but I was a little bit concerned that her creatinine was high at 0.88. That would sound normal to an adult, but if you do the calculation, that's about an estimated GFR of around 60. Albumin a little bit lower, 3.7, and a urinalysis showed 3+ blood, 2+ protein with some whites and some reds. And so, you know, I think, okay, well, next slide. So I saw her, and we actually got her in relatively quickly. I think must have had an opening. So she came into clinic 3 days later. And on physical exam, she had normal blood pressure. She didn't have any edema or facial puffiness. I did think she had swelling of her knee and ankle. And she had some sort of old residual lesions on her leg, which certainly could have been consistent with HSP, but they were mostly in sort of the healing phase. Although that's not that atypical in our patients with HSP nephritis, because the nephritis tends to be a later feature. And so I counseled the mom mostly around HSP and the fact that this was a relapsing remitting condition. Some patients do get nephritis, and that in those patients, sometimes the disease will self-resolve like the other features, but other times we need to do things like a biopsy and start treatment for the nephritis. But irrespective, she would need to be monitored closely. And then she left clinic and got labs, and then was noted to be slightly more anemic. And now her creatinine in 3 days had gone up from 0.88 to 1.2. An elevated ESR and normal CRP. She had normal complements, and as will be obvious in a few slides, I got no specific autoantibody testing, since the diagnosis seemed relatively clear to me at that point on a clinical basis. Her urinalysis was essentially unchanged. So next slide. So this is basically her trajectory. I don't know if I can use my pointer. Probably not. Anyway, it doesn't matter. But the creatinine of 1.2 was when I saw her, and I called the mom back and I said, you know, something is going on here. I think we need to get a biopsy to work out what's going on. And unfortunately, this was just before Christmas. I mean, looking at this timeline, we didn't do too badly in terms of getting our biopsy, but this was at the peak of the surge at Seattle Children's in terms of our number of patients. I mean, we needed sort of approval from the medical director to do anything. And I think we even had a biopsy slot on about day 7 of this, which she missed because she couldn't get a COVID test in time. And by the time she came into the hospital and got a biopsy, her creatinine was up to 1.5 and then spiked up to 1.8, 1.9, you know, during this admission. And so I'll let you show what the biopsy showed.
Yeah. So this biopsy has a really different appearance from the others that I've shown today. You can see that in both of these cores, there's some sort of a patchy process going on where you've got areas of well-preserved tubules, good-looking interstitium alternating with areas that look like there's probably inflammation and edema. And then you can tell even at this magnification that something bad is happening to the glomeruli. So there are a lot of them that look blue, which is the color of sclerosis in trichrome stain, and the others just look funny. Looking more closely, we observed that 44% of our glomeruli were globally sclerosed. And then among the ones that were intact, virtually every single one of them was involved by necrotizing and or crescentic lesions of varying ages. So in this image, you can see 3 globally sclerotic glomeruli. You can see a glomerulus that's involved by a very acute lesion, probably with a cellular crescent. And then this glomerulus down here is involved by a fibrocellular crescent. And then you can see this patchy interstitial inflammation with some tubular atrophy, kind of alternating with areas of better preserved interstitium. Here's another picture showing kind of the heterogeneity of these glomerular lesions, where some global sclerosis, some fibrocellular crescents, and then some more acute lesions here, probably with some like segmental fibrinoid necrosis happening in this glomerulus here. And then these guys down here look like they're probably a little bit longer, a longer standing lesion where you're starting to get some fibrosis. I thought it was particularly interesting to see that it almost looked as though some of these glomeruli had been hit twice by an inflammatory process. For example, this glomerulus here, you can see that the upper half is involved by a fibrocellular crescent, but then in the lower half of this glomerulus, you can see an acute necrotizing lesion with glomerular basement membrane break and fibrinoid necrosis. So it almost looks like some of these glomeruli got hit, developed a crescent, that crescent started to kind of mature, and then the remaining portion of the glomerular tuft got hit again by an injuring process, which is really not a picture that I'm accustomed to seeing. And really the sort of the variation in the age of these glomerular crescents was striking to me. Often in crescentic glomerulonephritis, we get the biopsy and it's a super acute process and everything looks really new. Or we get a biopsy and everything clearly happened at the same time a few weeks ago. In this case, it looked like stuff was going on a while ago and it was continuing to be ongoing right up to the minute the biopsy was taken. This image is to show that in uninvolved glomeruli, so here you can see a segmental lesion, but uninvolved portions of glomeruli looked really normal. We did not see anything that looked like a membranoproliferative process. We didn't see any significant basement membrane alterations, just a lot of crescents. More of the same. And then finally, this picture is to show that the interstitial inflammation where it's present was mostly lymphocytes, some plasma cells. So this didn't look like a typical HSP case to me. Occasionally we'll see crescents in HSP, but it's usually a small percentage of them, whereas this was basically raging. So I took it to do immunofluorescence microscopy, not knowing what to expect. And what I saw was not much. There was no IgG. Importantly, for the diagnosis of HSP, there was no IgA staining. IgM gave us this kind of focal and segmental kind of peripheral staining, which I think was just in areas of intraglomeruli. All the gloms for immunofluorescence that were intact were involved by crescents. And then like a little bit of focal and segmental C3 staining, which again was kind of underwhelming, and nothing else. And so based on this, I called that afternoon and I said, this isn't HSP. This is pauci-immune glomerulonephritis, and there are extensive necrotizing and crescentic lesions here, like 89% of the non-sclerotic glomeruli. There's a lot of chronic injury with 40% global glomerulosclerosis, and then this patchy interstitial inflammation and tubular atrophy. And whoops, and I gave away your thunder, Sean. I'm sorry. I suggested looking for ANCA.
And you were right.
Yeah. So this just, this looked like, and what was interesting about this is that our typical ANCA glomerulonephritis is a PR3, and this was anti-MPO. And what I learned from this case is that anti-MPO glomerulonephritis more typically can have this kind of indolent onset. And you can see it's more typical to see these glomerular lesions of varying ages whereas PR3, I think, tends to be less glomeruli, all with the same age of crescent to them. So this actually was a apparently fairly typical anti-MPO. I just hadn't seen very many before. The coda to this case is that a few days later, the electron microscopy came back, and there were surprisingly a healthy number of mostly mesangial electron-dense deposits in this case, which was really perplexing to me. And they were mostly mesangial. Sometimes they were present at mesangial waist, like you can see here, with well-preserved foot processes and otherwise normal basement membranes. Oops. Here's some here as well. Like you couldn't blow them off. They were really there. And then every once in a while, they'd kind of get out into capillary loops. And again, going back and looking at the immunofluorescence on this case, it was perplexing because I feel like where we saw this little bit of IgM and C3 staining, it was mostly peripheral capillary loops. It wasn't really a mesangial pattern. So I did a lot of head scratching about this and did a little bit of like sort of literature deep diving into what it means when you see immune complex deposits in pauci-immune glomerulonephritis. And what I found is that it's actually well described to see various patterns of immune complex deposits in some cases of ANCA-GN. So you can see co-occurrence with anti-GBM, which this wasn't. You can see co-occurrence with membranous nephropathy, which this wasn't. There are reports of ANCA associated with mesangial IgA deposition, which this was not. And then I found this older paper from Kidney International, which looked at 126 patients with ANCA glomerulonephritis, and they looked at the EM specifically, and they did find electron-dense deposits in a lot of these patients, usually either in the mesangium or mesangium and subepithelial. And many of them had immunofluorescence, usually not super bright, of which C3 was the most common thing that stained. And it's not clear what this means. Probably some cases are ANCA that's superimposed on another, like immune complex deposition process, perhaps like ANCA that basically kind of tsunamied over a smoldering case of IgA. But also there's this speculation that kind of pops up in the literature now and then about whether in ANCA glomerulonephritis, when you see immune complex deposits, whether those patients might have a worse clinical course, more proteinuria, whether something about the immune complexes kind of potentiates the ANCA glomerulonephritis. I don't know. It's confusing to me. I do think that everything about this case seems like it probably fits an anti-MPO ANCA glomerulonephritis. And I don't know what to make of the immune complex deposits, but it doesn't really change my position that I think this patient's major problem is her anti-MPO glomerulonephritis. Sean, do you follow up?
So the follow-up is she was treated with the rituximab protocol. So she got cyclophosphamide rituximab. Her creatinine has fortunately stabilized and started to come down. The most recent was down to 1.4 from a peak of about 1.9, which was fortunate because the family, I think at around the time that the creatinine was not coming down, was sort of threatening to leave and go to a different institution that knew what they were doing better. So I think she's done about as well as one could have expected based on 44% globally sclerosed and everything else being crescentic, but I'm certainly worried about her in the future, given how much injury she sustained.
Yeah, that was my worry too, looking at this, because sometimes you look at ANCA glomerulonephritis and you can see how if you can kind of calm it down, that there's like plenty of healthy nephrons still left there. Here, it was like virtually every glomerulus was involved, and these mostly weren't small, subtle crescents. They mostly were just kind of overpowering the entire glomerulus. So even if you can make those stop occurring, I agree with you. I'm a little concerned as to what's going to be left in her parenchyma.
Yep.
But it's good to hear that her creatinine's back down to something a little bit less hair raising.
Yep.
Yeah. Any comments or questions on that interesting case of HSP?
I would just add another interpretation of the immune deposit you're seeing.
Oh yeah, that'd be great.
It's just part of the normal scarring process. So I'm not sure if you got how involved those glomeruli are, but if you do get some glomerular injury, you can get natural IgM antibodies from complement fixation, happening, and that happens, commonly in areas of sclerosis. And so it could be part of an evolving process of sort of injury and repair. That's just sort of a physiological process that happens all the time, and it's just augmented in areas of injury.
That's interesting. Wow. So that would indicate that you might expect to see immune complexes in the setting of anything that causes glomerular injury.
We always see it in segmental sclerosis and diabetic nephropathy, and arterial sclerosis. Yeah.
Huh. I got to look harder. All right. Wow. Yeah. I feel like I do see IgM staining in a lot of injured glomeruli. That I'm comfortable. I think of that as IgM is a big sticky molecule, and it just I think of it as just kind of like getting caught in areas of injury.
Yeah, I'm not a fan of that interpretation. I mean, it's big, but it's not so big that it's going to get just stuck because of its sheer size. So
no, that's true. But I feel like I see IgM staining, but I don't feel like I see the electron dense deposition by EM as often. But maybe I just need to look harder. Yeah. All right. Thank you, everybody, for attending this talk. I really appreciate your attention and your comments.